So, hi everyone. Thank you for staying to the end of the day. I am Casper from Fraser Health, and for the next 30 minutes, want to give you our journeys in both developing and also deploying AI to improve our healthcare system. My goal is to inspire, to share, and to learn with all of you guys as well. So just a little brief, quick bio about myself. I've been with organizations close to 10 years now. I'm a senior director with the organization in the department called CATSI, or Center of Advanced Analytics, Data Science, and Innovation. And I lead the data science and also the analytical teams together with my peers. End to end, we do the combination of in-house consulting, the in-house analytical production, as well as the data warehousing and data engineering aspect. So what I want to cover is both a combination of what is our digital health strategy, how we have the foundational blocks enabled for developing our AI solutions, two examples of the solutions that are in active clinical use today, and then the future direction of where we are going. So for those who may be newcomers to BC, Fraser Health is one of the 5 health authorities in the province. We are the largest in the province, serving more than 2 million people. And so it's about 1 every 20 Canadians pass through our healthcare system. There's about 12 hospitals, one soon to come online as well, so soon to be 13. But beyond the hospital care, we also have the networks of the community side as well. So primary care clinics, home health, home support, the mental health addiction treatment centers, and so forth. So in terms of our digital health strategy, ultimately at the end of the day, we want to digitize the interactions of our patient journey, vir- provide virtual care services where possible. So moving beyond the traditional brick and mortar approach, but introduce the virtual technologies. And the impact of this ultimately is to move towards operating at 75% census. I think all of us probably have experience going to the hospitals and experiencing the high volume of congestion, long wait time. And that is a sad reality. Right now, on average, daily, we're looking at about 110 to 120% occupancy in our hospital. So it is almost consistently way more than what is the hospital funded for. But there is a silver lining here, which is with these digital technology combined with the value that we can get from these data points, then it allows us to improve the healthcare operations. And as the theme of this conference here is on analytics, is where we can get the predictive insights, but also to inform the prescriptive solutions to ultimately allow our clinicians, the operational leaders, to be more proactive in addressing the business pain points. So this is where we are at with our journey. We are quite proud to say we actually currently have just slightly over 40 different AI initiatives underway in various stages from in the initial scoping development, but also quite a few now in the active pilot and clinical production. And these span across 3 main streams. On the left-hand side, this is what we call the in-house development. So we have our in-house AI team, and we do a lot of the internal things in-house. But we also do co-creation as well. So partnership with third-party entrepreneurs, the local startups, and whether the local to the province, to Canada, but also a partnership with like Mayo Clinic down in the States or around the world too. And then in some cases where the market maybe is already there, don't need to reinvent the wheel if it's already there, then that's where the vendor license comes in, the traditional buy approach, procuring a product that has already been very well established and validated. And in the healthcare domain, this is usually where the diagnostic AI comes in. That has been already a few quite mature products out there. And in terms of enabling the analytics, the first foundational block, just to briefly share, is what we call our analytics management framework. This is our operating model. And at the heart, what it basically says is when people come to us asking for data, we don't just transact on it. We want to make sure we understand the business pain point behind it. And then when we built to address that pain point. It's not about delivering the technology or the solution, but it's about improving that user experience, creating the delight. So that is actually a transformative mindset that we have to bring, especially to our organization, because we have to come from a culture where people will often come to our data team already with certain data points they have in mind, and they just want the data, and we have to uh, shift that mindset so that we are actually also there to work with them to really figure out what is their business pain point and where the opportunities lie. The second part is the data foundation side. So we have what we call our Fraser Health data lake. It's more than 16 plus terabytes, and I believe every day there's about 30 gigabytes of data being added as well, and more to come as more patient touch points becomes digitized. And the powerful thing about this is it links the patient journey together into one centralized view to form that end-to-end patient journey. So imagine if you're a patient, maybe you don't feel well today, you go to the emergency department, maybe you need to get admitted to the hospital, go through different hospital services, and then maybe you get discharged, and there's a referral to a home health support. All these right now touch on a different IT technology system, but regardless of what system it's going through, we're able to collate that and centralize it. So from the analytical side, we have that very strong foundational view as the patient goes through. And this becomes the bedrock for feeding whether the traditional reporting, but more importantly, the AI solutions as well. Building on the presentation from earlier, our organization also has the responsible AI principles. So this is a third fundamental piece that we are able to get through. And it basically speaks to the various principles that needs to be checked before AI is deemed as safe for the whether piloting or the broader use. So things like the data quality, data drifts, performance drifts, how is the human in the loop process being defined, the accountability and so forth. All of that, these are principles and then in turn translate to the appropriate guardrails for the technical teams to have in place. The first example I want to talk about is what we call the AI-enabled identification of the discharge readiness. So in the pre-AI world, the way our hospitals are used to run is the clinicians will have daily discussions as a team to discuss which patients are likely ready for discharge. And the challenge with this is it can be quite reactive. So say if a patient is medically stable, ready for discharge, but the family hasn't been informed yet. So now there's kind of like a last minute scramble to get the patient ready. Or maybe the patient needs a social worker, but the referral hasn't been made. There's a bit of that delay. And then the outcome is the patient now has to wait 2 more days in the hospital, which is bad for patient care, but also bad for the health system, the patient flow as well. So the idea then is we have all this rich data. Can the AI then inform which patient could be ready for discharge, say in the next 24 hours or in the next 3 days? And this is what we have done. We use the data from our data lake, and we first started with 2 sites on how the algorithm performed, and now we have scaled it to all our 12 hospitals. And the impact of this just becomes a lot of time saving for the clinicians. They're able to take what the AI is recommending. So to be clear, the AI is not determining who should be discharged. It's prompting who likely are ready for discharge. And then the clinical team is able to utilize this list to then discuss which among them is it truly ready, and then that streamline the discharge conversation. So one of the powerful narrative we heard from our clinical operation leader is, so typically before the AI, we're looking at about 300 to 400 patients able to discharge on any given day. And with the tool, we are now actually seeing more closer to 500 discharges, which previously was never heard of in the organization. Now, there are other factors at play. So I'm not saying only the AI is responsible for the rise from the 300 to 400 all the way to 500, but it definitely has helped streamline the daily round planning that the clinicians go through. And how the tool looks like is we embed it into an existing technology, and then to streamline to their workflow. So this is it's not a real number, but just you can see the layout, which is we have what we call our live occupancy dashboard that shows at any given point in time how crowded is the hospital at the hospital level, program level, and unit level. And then at the last column is where first, in the aggregated form, we show how many patients likely are ready for discharge. So say at the Abbotsford Hospital, based on what the AI has shown, certain number of patients theoretically can be discharged. The clinician can then further drill down from this tool to see the actual line list of where those patients are, which bed they're located at. And then to streamline the conversation, we also automatically surface some of the key variables that the patient, the care team needs to know to streamline the conversation. So 3 lessons that we have learned as a result from this. First is the clinical partnership. It is really important to get the clinical champion to foster that trust. What we learned is that we have to bring the clinicians along in every step of the way. It's not just kind of we have the problem, we go into our computer, we have the algorithm, then we come back. Because that to them, then the AI just becomes a black box. It's very hard to get their buy-in. We actually have to work with them, even say during the feature collection part, tell them like these are the variables we are considering to try. These are the ones that the AI had picked up as informative. Does it make sense? And there's that iterative dialogue, because sometimes the clinicians will say, I know the AI think this is important, but this is really making me uncomfortable. Maybe this data point, the way it's collected, it actually doesn't make sense. So like there is that domain-specific knowledge that guide our AI training as well. And then there's also the part about the process integration. So as I mentioned earlier, in the case for our predictive discharge, the key success actually isn't just the AI itself, it's the clinical workflow that wraps around it. So we have a very well-defined role and responsibility on who's going to read these AI output and what type of action needs to be taken place and in what format are these reviews being conducted. So there's that downstream clinical workflow that we support the clinicians to ensure there is an action being taken place accordingly. And then finally, it's also the continuous mindset of that AI is not a one and done. The analogy we actually use in the organization is AI is like a person growing. So from zygote to embryo to a baby, a child. So I'll say probably our predictive discharge is in the form of a baby right now. We are quite excited to keep trying to continue to improve the performance. Right now, it is about 86% accurate, which we found to be a 4-fold improvement over the existing clinical judgment. So it's already really good, but we want to continue to try as well. And also, there's some further opportunities, such as beyond just surfacing which patient could be ready for discharge, we also want to see if the AI can now list the main discharge barriers that could be the reason why the patient may not be discharged on time. So then the clinicians can more focus on what those barriers could be. I have a bit of time. The second example I want to show is on the generative AI application for clinical documentation. So my earlier example was more about streamlining the operational flow, and this one is going to be more on the Gen AI use case. And the context behind this is that when we talk to any clinician, the number one pain point they will say is how much time they are spending in front of the computer. A lot of documentation. I think the one clinician even say, on average, every day he has to document about 7 pages, like font size 12, single space. There's a lot of documentation, and people often have to work like past 7 p.m. in the evening all for documentation. So one of the idea in which in this case, we partner with our clinical solution provider is called Meditech, and we also partner with Google AI, where I'm going to go to this slide. Imagine you are a physician and you need to write up the patient chart. There's a button where you just have to press in a few seconds, then the AI will generate what the patient summary that is appropriate for that particular chart. Now, the human is still in the loop. So in this case, it's only a draft. The physician still has the final accountability to review, to sign off, and there's a process documented in the clinical solution. But the idea is because bulk of the work now is complete, the physician just has to review, make any edits as needed. We want to aim for 90% time saving in the chart. And now by giving the gift of time back to the patient care, this would also improve the patient care as well. The other benefit also is by standardizing these charting format, it will also streamline when one provider hand off their patient to another, because that is also oftentimes a cause of delay or harm in patient care too. Oftentimes the documentation is incomplete when one most responsible provider hands the patient to another, when one shift ends and then another shift begins. So by having the AI helping in the completeness of the chart documentation, that's also another way to improve the patient care too. So beyond just the time saving itself. Finally, for the future direction, I'm going to skip these two, just to highlight where we are going from an analytical perspective. Really, what we're aiming for is building that one-stop shop platform and streamline the user experience. As I mentioned before, our organization already have more than 40 plus different AI initiatives underway. But the last thing we want is for the end user to feel there's now 40 different technologies they have to learn. Can it all be in one place? So anything to do with analytical data insights, just this one-stop shop they have to go. And that's part we're building towards. And this ties to the digital twin initiative that our organization is going through right now at the moment. So picture how when you have whether the descriptive, the diagnostic, or the predictive and simulation modeling all in this one place. So if a clinician needs certain things for his or her needs, there's that need. But then also for the executive level, such as planning the long-term healthcare spending, the budget allocation, the digital twin will allow you to test out different scenarios and how would the different scenarios impact the patient flow, impact the patient quality of care. And that's the vision we're building towards too. Yeah, so that's. Oh, we have a frequent flyer again.
Thank you, Casper. That was really informative and it was really beneficial for the patients. I just wanted to ask you with the second project that you outlined where physicians are using AI to summarize notes or make it faster, where is that data housed and how do we ensure we protect the privacy of the patient information?
Yeah, so for every AI initiative, it needs to go through what we call the PIA, the Privacy Impact Assessment, and also the STRA, the security side as well. So both privacy and security teams do their diligence on that. In the case for that particular project, we did have the guarantee that the data actually so the source of the data is all on the clinical system, and then there is a transient data where it's sent to the Google LLM, the Gemini, and then it's sent back, and that's the part that definitely needs to be like encrypted. There's no storage on the Google side, and anything is only transient and then make its way back. Like all these architectural consideration, definitely the privacy and security team that work through that.
That's great. I just want to protect my data there. Okay, thank you.
Thank you. I only have one question. So in the first example, you talk about the AI model discharge, right? So the decision is either discharge or stay, right? It's a binary.
Yes.
Okay, so if I do not know anything about that, the first thing come to me is why not just use the binary regression, use the generalized linear model instead of just use the AI. So which make you decide to use AI, not the binary regression?
Yeah, I would say it's actually a combination of both right now at the moment. So the output right now is binary. So the overarching, you can kind of see it as a binary classification. But one of the things that we actually did, which led to the biggest performance increase, is embed the large language model to process the unstructured text so that the insights from the unstructured text becomes input to a downstream AI module. So it's kind of like two different AI modules working in tandem as one single AI pipeline. Because like 90+% of the healthcare data is unstructured. So that's in particular something we had to really work hard to make sure, can we mine that in an algorithmic way and feed that to the classifier?
Thank you. So it's kind of unstructured and also non-linear. That's the reason, right? Okay,
Yeah.
thank you.
Thank you for the question. And I'm saying that sort of with a smile, but I think that the audience asking questions is really important. And it's important for the speakers to know that people are engaged. So I may make light of it, but thank you very much.
Thank you, Casper. John Schwank from Informatica. I've heard of one project in Ontario under University Health Network where they're doing AI or using AI in some sort of a trial to try to more efficiently admit patients to emergency. So assessing whether they need blood tests before they see the physicians and the nurses. Is there any collaboration between Fraser Health and other jurisdictions on things like that?
Yeah. I'm not sure if you may be referring to Scale AI from Scale AI Signal One from that organization, but we definitely are building our network collaboration. That's part of the innovation ecosystem that we are aiming for. So not just within BC, but the partners in Ontario, the Mayo Clinic, there's a Hamilton Health, a Humber River. These are all different kind of organizations. We want to build that broader collaboration. Sometimes the data sharing and the use cases can be a little difficult to partner well, but at least starting with the basic knowledge sharing and seeing what each other is working on, definitely that's something we're working on.
Wonderful. Any other questions? Oh, yes.
Thanks so much. It looks like amazing work that you're doing. I noticed on the first module for the discharge rates, you said the model can be 86% accurate. When you look at the success criteria of those models, are you kind of working it with the clinician? Like, for instance, do you look at if there's any uptick in readmissions or anything like that, just to see that those 86% that got discharged didn't increase like a readmission rate or anything like that?
Yes, yeah. So for our AI work, the one right off the bat in the beginning, what we do is also map out what are the different ROI metrics, so we're able to justify the success, and readmission definitely is one of them.
Wonderful. Is that our last question? Okay, wonderful, Casper. Thank you very much. That was excellent. Yeah, just give it back to him.